promoting health for children and youth with special care needs. Children and youth with special health care needs make up 20% of the childhood population, or 14.6 million children. They are defined as children who have or are at increased risk for chronic conditions, including physical, developmental, behavioral, or emotional, which require an increased demand for healthcare services than that of the general child. 40% of these children are technology dependent. This would include things like trachs, feeding tubes, ventilators, and central venous catheters. Hospitalization rates for those children that have more than one complex condition are far greater than those children that only have one complex condition. Thanks to the advancements in healthcare technology and research, these kids are now surviving and thriving. Family and patient-centered care is essential. They have an increased need for primary care services. This is requiring development of new practice models and new expansion and innovation on the formerly known pediatric home care. Frequently, multi-team interdisciplinary care is required to meet the primary healthcare needs of these patients and families. An integrated medical home and shared plan of care includes things like active engagement, strong, clear, and frequent communication, holistic family preference-based approach, mutual trust and respect, family-centered informed decisions, shared goals with accountability, team monitoring of progress and goals while adapting and modeling the plan of care continually, planned transitions into adult care, a plan of care that is systemized and shared, leading to a result of well-coordinated care across all organizations and all systems. Palliative care is a discussion that happens with children and youth with special health care needs. The goal of palliative care is to have these children live their best life, regardless of prognosis or life expectancy. Palliative care keeps the family in mind. Chronic health conditions affect the entire family, parents, siblings, extended family. The focus of palliative care is pain and symptom management, information sharing, advanced care planning, practical, psychosocial, and spiritual support, and care coordination. When considering the special care needs of birth to 11 months, some things come to mind. Preterm, low birth weight, or birth defects often need chronic health and developmental needs, support for parents, long-term resource education, a guided transition to home, and anticipatory guidance addressing the parent's concerns, goals, and expectations. Specific guidance that occurs during this time period resolves growth and development, specialized care, feeding concerns, plans to achieve milestones. Explore understanding of condition and how preferences will impact care coordination throughout care. Identifying risks and referring for early intervention. For example, the program for infants and toddlers with disabilities, or in Missouri, we have First Steps. Healthcare professional provides an informed clinical opinion. The developmental surveillance and formal evaluation would include surveillance being important to any child, but if there is failed development cited, formal evaluation is required. Early intervention, parent engagement, and follow-up is essential for the success of these kids. We should also, at this time, address the parent-child relationship and ensure that bonding has occurred, which can be difficult, especially if the infant is hospitalized. For the child with special care needs, ages 1 year old to 4 years old, responsibilities of the healthcare professional become prominent. The healthcare professional must address the known problems, but also to diagnose and manage new arising needs in this period of rapid growth and development. To listen to parent observations and concerns regarding development and milestones. Parents know their child best, and they have a 24-hour watch on them. We should engage the parent and listen to their concerns. This will lead to a proactive approach. Concern always leads to referral. This also assists in providing a medical home by ensuring adequate resources are in place to ensure success. Parent-to-parent support groups can be important in this time. Things like emergency plans are essential for those who live with or are in care of the child. This can include plans for what to do in an event of hypoglycemia, a seizure, or a trach-related emergency such as plugging or accidental decannulation. For the child with special care needs ages 5 years old to 10 years old, critical involvement and adaptation takes place. Active involvement of the child in their care allows for successful adaptation to the conditions. There are large transitions that occur during this period, such as the beginning of kindergarten, or, as it progresses, the beginning of middle school. The increasing educational, social, and self-care management demands can be a challenge to both the child and the family. Children adapt best when healthcare professionals, parents, schools, and communities rally together to foster emergence of independence. Special accommodations may mean contact with prejudice and misunderstanding, especially in the school environment, which may lead to isolation and stress. Providing information for teachers and schools to better understand the special care needs of a child has the capacity to improve school performance and increase classmate acceptance. Medically fragile children should always be challenged and not given special privileges simply because of the condition. This can be a sore subject between children with special care needs and their healthy siblings or classmates. Special care needs for the 11-year-old to 21-year-old population faces the challenge of meeting puberty head-on and developing beyond. Puberty brings remarkable physical and emotional development and fosters new levels of independence and autonomy. Careful assessment leads to better identification of risk-taking behaviors, strengths, conditions, and newly developed physical and emotional maturation. Healthcare professionals encourage an active role for the adolescent in ownership and decision-making of their care. Time alone with the provider is still essential to discuss topics of substance abuse, sexuality, and academic performance that the child may not otherwise feel comfortable discussing in front of their parents or caregivers. As these children and youth transition to adult care, this is met with great challenge. The goal is that this completed transition occurs by age 25. It is introduced in early adolescence for modification as adulthood approaches. It is important to assess development and the youth's ability to assume responsibility for management of care. Decreased decisional capacity should always be managed by a legal guardian. This is a trying time for both the adolescents transitioning out as well as their families and caregivers. After all, the practitioners they are used to seeing have known them likely their entire life and are experts in their care. However, it is important to ensure this transition. Thank you for your consideration of how to promote health for children and youth with special care needs.